Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria, and I am currently a PGY5 resident at the University of Pittsburgh. Today, I'm very excited to launch into a brand new series on pediatric cancers, starting with an overview lecture on pediatric CNS tumors. There are many different types of CNS tumors, and I think there are some things that are similar about a lot of them, and then there are some things that are different. I would say what is similar about a lot of different CNS tumors is their general presentation, because a lot of times they tend to be posterior fossa tumors, and the initial workup is very similar for a lot of these tumors as well, because we typically manage most of the time with upfront maximal safe resection. What tends to be different is, the distribution by tumor type, the prognosis of the different tumors, and then the general management. So, a lot of these tumors are managed with adjuvant radiation, with or without adjuvant chemotherapy. And that is, I think, where things get a little bit different for these different tumors. So what I would like to do in this overview talk is really start with what is similar, talking about the background and the tumor types and kind of stuff that broadly applies to many of the pediatric CNS tumors. Then I have a brief slide on the general management. So it's basically a table listing out some of the common types of pediatric CNS tumors and a very general blurb about their treatment paradigm, including the role for adjuvant radiation, as well as chemotherapy. And then for this talk, I would like to end with a discussion on craniospinal irradiation, which is something that comes up a lot on boards, especially kind of the 3D technique and how we set up fields for craniospinal irradiation and all of that. So we'll wrap up this overview talk by talking about CSI. And then in the future, I will have dedicated talks for the different subtypes of pediatric CNS tumors, starting with some of the more common ones, and then, hopefully eventually we'll build up these videos and have videos on even the more rare ones as well. Let's start with some general background. So pediatric CNS tumors account for about 15 to 20% of all pediatric malignancies, and they make up the second most common childhood malignancy, second only to hematologic malignancies. So hematologic malignancies, think leukemia, are the most common in children, and then pediatric CNS tumors are second most common, accounting for about 15 to 20% of pediatric malignancies. They are actually the most common cause, so the number one most common cause of pediatric solid tumors, and they're also the leading cause of cancer death in children that are age 0 to 14 years old. In terms of incidence, between 2015 and 2019, the incidence was about 6.3 per 100,000 cases in the United States, and it was nearly a 50-50 split. So close to 60% of cases were malignant, 58%, and then 42% of cases were non-malignant. And one thing that we learned going back to medical school is that about 2/3 of the time, pediatric tumors are infratentorial. So they are usually located in the posterior fossa. Think about 60 to 70% or 2/3 of the time they're in the posterior fossa or infratentorial. And pediatric tumors are also more likely to be low grade. And this is in contrast to adult primary CNS tumors, which are more commonly supratentorial, and they tend to be higher grade. So GBM is the most common primary CNS tumor that we see in adults, right? Glioblastoma, and that's a high grade tumor. In children, they're more likely to be infratentorial. They're more likely to be low grade. The presentation, of course, depends on the anatomic location of the tumor. So posterior fossa tumors, which are probably the most common, tend to present with symptoms such as early morning emesis, recurrent emesis, ataxia, facial weakness, diplopia. Suprasellar or chiasmatic tumors, so think something like a craniopharyngioma, can present with failure to thrive, anorexia, visual field deficits because the optic chiasm is just superior to that area, precocious puberty or delayed puberty, as well as diabetes insipidus. Tumors of the cervicomedullary junction can have symptoms such as head tilt, dysphagia, drooling, torticollis, and weakness. And then tumors of the pineal slash midbrain area, they can cause, so something like a pinealoma, impaired upward gaze, dysconjugate gaze, as well as tremor. And then finally, if it is supratentorial in the cerebral cortex, we can get seizures, weakness, encephalopathy. And then cerebellar tumors kind of differ in their symptoms depending on whether they are in the midline or in the lateral regions. So midline cerebellar tumors have symptoms like truncal or gait ataxia, so a broad-based gait, difficulty with heel-to-toe walking, head bobbing, and nystagmus. And then lateral tumors have symptoms such as dysmetria on finger to nose testing, intention tremor, difficulty with heel to shin test. So midline tumors, think things that are more sort of axial, so truncal or gait ataxia, head bobbing, nystagmus, so axial skeleton things. And then lateral tumors, more appendicular, so finger to nose testing, tremor, heel to shin test. So those are kind of the appendages versus the trunk. There are certain tumor predisposition syndromes, and these are all things that you probably studied back in medical school, and it's good to be familiar with the syndrome, the genes that are known to be involved, as well as the typical brain tumors that are associated with these different syndromes. There's a lot here on this slide, and I'm not going to read through it all just for the sake of time, but I will leave it here for your reference. This one's probably a more user-friendly chart that has some mnemonics for some of the common tumor predisposition syndromes, such as neurofibromatosis 1, which is associated with a lot of things, among them astrocytoma. Neurofibromatosis type 2 is also associated with certain brain tumors, including meningioma, ependymoma. We have tuberous sclerosis, which is associated with rhabdomyomas, also astrocytoma and GBM. And then we have von Hippel-Lindau syndrome. So again, not going to read through all of this in detail, but here for your reference. When children present with any of those concerning symptoms that we went over previously, their workup should always begin with a complete history and physical, inquire about their birth history, medical history, family history, any genetic syndromes that we may be concerned about. And then in the exam, we definitely want to perform a complete neurological exam, examining their mental status, cranial nerves, sensation, motor function, and full cerebellar exam as well, assessing their gait, coordination, also assess their reflexes. A skin exam can be helpful to assess for potential dermatologic manifestation of various tumor predisposition syndromes. So, for example, neurofibromatosis type 1 can present with neurofibromas as well as freckles. And then ash leaf spots are one of the symptoms of tuberous sclerosis, or one of the manifestations of tuberous sclerosis. So various syndromes have sometimes skin findings that may be associated. And then there can be concern for increased intracranial pressure because a lot of these posterior fossa tumors can obstruct the CSF flow if they are either in or compressing on usually the fourth ventricle. So if you're able to perform a fundoscopic examination, you might be able to evaluate for papilledema. But anything that makes us concerned about increased intracranial pressure, like if they have headache, if they're presenting with nausea or vomiting, if their vital signs are unstable, obviously these patients should be directed to the emergency room. In terms of imaging, typically the first imaging that we'll obtain for any child with neurologic abnormalities, or even any adult really, is a CT of the head without contrast, just to rule out, bleeding, if there's any impending herniation, acute hydrocephalus, things like that. And then MRI with and without contrast is the gold standard for visualizing brain tumors. So MRI with and without gadolinium contrast. Now, typically the brain MRI is obtained first. Usually there's some abnormality on the CT head without contrast, which prompts a brain MRI with and without contrast. And then the first step in management is typically going to be maximal safe resection. And after maximal safe resection, these patients will need a postoperative brain MRI as well. And ideally, we obtain that postoperative brain MRI within 72 hours of surgery. So ideally, we do it within 24 to 48 hours of surgery, but 72 hours max after surgery. And the reason for this is that there can be maturation of blood products. And after 72 hours, and obviously this is a gradual process, but as more time passes after surgery, those blood products can become hyper intense on MRI as they mature. And if we delay the MRI too much, then it's difficult to differentiate enhancing brain tumor versus just hyper intense blood products. So we try to get that postoperative MRI, ideally 48 hours, at most 72 hours after surgery, just so we can assess the degree of resection. And then a spine MRI is also needed. And if it's not done pre-operatively, then we typically get a spine MRI 10 to 14 days after surgery. And the reason for this is to avoid, any artifactual change from surgery itself. So just to avoid any confounding there, we try to wait 10 to 14 days for that spine MRI. And then labs, and obviously labs would be done before the patient went for surgery and things like that, but basic labs that we think about are a CBC and a CMP. For germ cell tumors, we also typically test AFP, beta HCG, and LDH. But minimally, patients would have CBC and CMP, and then if we are concerned about germ cell tumor, we would also get beta HCG, LDH, and AFP. And then a lumbar puncture with CSF cytology is typically needed for CSF staging. And this is typically done 10 to 14 days post-operatively as well to decrease the risk of herniation. We don't want to do a lumbar puncture so soon after they had surgery, just because there is a risk of herniation. And from there, we really do want to make sure that our multidisciplinary team is consulted and on board. So not just neurosurgery and neuro-oncology, but also neuroradiology, genetics, endocrinology, ophthalmology, audiology, neuropsychology is needed to assess a baseline IQ, physical medicine and rehab, palliative care, social work, a lot of pieces are needed to get these children treated, so making sure that we have this multidisciplinary team. I want to take a moment to point out that the way that we rate pediatric patients' performance status is using something called the Lansky Play Scale. So in adults, we're familiar with the Karnofsky performance status or the ECOG performance status, and the Karnofsky and ECOG, are on this scale, and they really kind of utilize activities of daily living and instrumental living and things like that to relay how functional a patient is. Well, children, depending on their age, are often not, expected to change their own clothes, cook for themselves, balance their checkbooks, things like that. And so the Lansky Play Scale is kind of an analogous scale to the Karnofsky performance scale, but using activities that are expected of children. So 100% is fully active child, normal child for their developmental stage. 90% is minor restrictions in physical or strenuous activity. 80% they're active but tire more quickly. 70% they have greater restriction and less time that they're able to actually play and be active. And then, as we go down, you can see that the activities that are in the Lansky performance status scale very closely mirror those of the Karnofsky performance status scale, but this has more to do with how the children are playing and what activities they're able to do that are normal for their age. So just as a note, when you're writing your note and you're assessing the performance status for the patient, use the Lansky Play Scale rather than the scales that we use for adults. So now that we've provided a general background of, epidemiology, presentation, and general workup for pediatric CNS tumors, let's move on and address some of the different tumor types that we see in pediatric patients. As we said earlier, about 2/3 of primary CNS tumors in pediatric patients are located in the posterior fossa, so they are infratentorial. And the majority of pediatric brain tumors are actually low grade. This is in contrast to adults, where the majority of primary CNS tumors are higher grade. So, gliomas are probably the most common subtype of pediatric CNS tumors, and the most common subtype of a well circumscribed astrocytoma is a pilocytic astrocytoma. This is the most common CNS tumor that we see, and the management is typically with resection alone, and most of the time does not need any adjuvant radiation. Even if there is residual tumor, these tumors are low grade, and so we tend to kind of monitor them and just make sure they're not growing or changing over time, even if there's residual. So that's pilocytic astrocytoma, probably the most common tumor that we see in pediatric patients. There are many other subtypes that are listed here on this slide. The only other glioma that I'll draw your attention to are the diffuse high-grade gliomas that we see in pediatric patients. So diffuse midline glioma is one of these that we see, and it often is associated with an H3K27 alteration. And this is something that there are ongoing trials to try and target and improve the prognosis. So unlike pilocytic astrocytomas, which are low grade and these patients often do very well, diffuse midline gliomas have an exceedingly poor prognosis. They are often not even able to get any tissue sample from these tumors because of the location. They're often, diffuse midline pontine gliomas, so they are kind of involving the entire pons, and obviously we're not going to stick a needle into the brainstem. So it's very difficult to even sometimes get tissues from these tumors, and these tumors have a very, very low survival rate. The median survival is on the average of 1 year or even less. So that's kind of a range, right, represented by gliomas. With most commonly, we see lower grade tumors such as pilocytic astrocytomas, but every once in a while we do see a diffuse midline glioma. Oftentimes it involves the pons, and so we can't even get a biopsy. We try to get a biopsy if we can. Again, maximal safe resection, we always try for that. But if it's not possible, then we sometimes have to just treat empirically. And so radiation does end up playing a role for those diffuse midline gliomas. Other tumors that we see include ependymomas, which make up about 10% of pediatric CNS tumors, and about 90% of the time these tumors are intracranial, but once in a while they can also be spinal cord ependymomas. Embryonal tumors, so medulloblastoma is another common pediatric CNS tumor that comes up a lot on exams. It accounts for about 6 to 7% of pediatric CNS tumors, and medulloblastoma is unique because after maximal safe resection, we often manage these patients with craniospinal irradiation as well, which we'll talk about a little bit later in this lecture. But medulloblastoma is probably the one pediatric CNS tumor that almost all of the time we're thinking about craniospinal irradiation after maximal safe resection. For ependymomas, we think about it, but only if patients have spinal metastases. We don't routinely offer prophylactic CSI, but for medulloblastoma, we actually do. Other embryonal tumors, so atypical teratoid rhabdoid tumor is one that comes up, and there are a couple of other subtypes that are listed there. About 15% of the time, pediatric patients might have tumors of the sellar region. So these can be pituitary tumors like pituitary adenomas, or also craniopharyngioma. And tumors located in this area often present with that bitemporal hemianopsia because the optic chiasm is located just superior to this region. And then just to round out the different types of CNS tumors we see, additional tumor types include glional and neuronal tumors, tumors of the cranial and paraspinal nerves such as schwannomas, neurofibromas, malignant peripheral nerve sheath tumors. We can also see meningiomas in pediatric patients. And another thing to note is that meningiomas can be kind of a secondary malignancy that happens after children are exposed to craniospinal irradiation as a child. So meningiomas can pop up as a long-term effect of that as well. And then finally, lymphomas, primary CNS lymphomas are very rare, accounting for less than 1% of all pediatric CNS tumors. So I think it gets very confusing because there are a spectrum of different types of primary CNS tumors that we can see in children. And it's really difficult to kind of keep track of all of the ones that I had on those slides that were listed. So I think the key takeaway is that, again, as we said, about 2/3 of pediatric CNS tumors are going to be posterior fossa tumors. And so things that are common are the things that we tend to see most often in clinic, and also the things that tend to get tested most often. So there is a nice mnemonic for the differential diagnosis of a pediatric posterior fossa mass. And the mnemonic for this is GAME, G-A-M-E. So glioma, such as a brainstem glioma, astrocytoma, such as a juvenile pilocytic astrocytoma, medulloblastoma, and then ependymoma. So GAME is the mnemonic for the differential for a posterior fossa mass in a pediatric patient. So once again, just to repeat, glioma, such as a brainstem glioma, astrocytoma, such as a juvenile pilocytic astrocytoma, medulloblastoma, and then ependymoma. Other things that can be on our differential that are less common, so lymphoma, hemangioblastoma, dysplastic cerebellar ganglioma, and ATRT, which is that atypical teratoid rhabdoid tumor. But I think if you remember the GAME mnemonic, that's a good place to start for your differential of a pediatric posterior fossa mass. Just to reiterate, this pie chart has another kind of representation of the distribution that we see by tumor type. So again, pilocytic astrocytoma is the most common primary CNS tumor that we see. So again, a low-grade glioma tends to be most common in pediatric patients. Other types of tumors that are on here that we've talked about. So malignant glioma is on here. Embryonal tumors account for about, on this pie chart, it says 11%. And medulloblastoma by far accounts for the majority of those, accounting for about 2/3 of the embryonal tumors. Other types of embryonal tumors are those ATRTs, so the atypical teratoid rhabdoid tumor, and then PNET. And then, we see pituitary tumors on there, other astrocytomas, ependymomas, and then as we get into that kind of upper left side of this pie chart, things become even less prevalent. So just another depiction of the prevalence of these tumors. And again, these percentages might not be exact. The source I have cited here is a little bit dated as well, but just gives a sense of what are the things that are most common. And again, always go back to that GAME mnemonic. So glioma, astrocytoma, medulloblastoma, ependymoma. And then finally, we have to realize that these tumors are very heterogeneous, not only in their origin, but also in their kind of natural history and prognosis. So this table shows, the prognosis based on tumor type for various primary CNS tumors. And as you can see at the bottom of this chart, things like a pilocytic astrocytoma, low-grade glioma, and then even craniopharyngioma, medulloblastoma, these things tend to have a much better prognosis. Pilocytic astrocytoma, the 5-year survival is on the order of 100%. For something like medulloblastoma or craniopharyngioma or pinealoblastoma, it's somewhere, between 80 to 90%. And then as we go further down this chart, we see ependymoma up there where the 5-year survival is somewhere around 60%. Embryonal tumors are up there as well. And then diffuse intrinsic pontine glioma, that's a DIPG, which is, again, that high-grade glioma, often has the H3K27M mutation. And we see that the 5-year overall survival is in the single digits range. These patients do very, very poorly. So the prognosis is very, very heterogeneous as well. And it's important for us to realize, what that prognosis is when we're treating a patient and be realistic about what our goals with treatment are as well. And then on the flip side, for our patients that do very well and do have a high expected long-term survival, we need to be very conscientious of the treatments that we're offering and what types of side effects they're going to have for them in the future too. So now, continuing in this vein of a very broad overarching view of the landscape of pediatric CNS tumors, I'd like to kind of move into the management of these tumors and again just list out some of the most common tumors that we see and get tested on and talk about in general how these tumors are managed. The first step in management is typically upfront maximal safe resection. So that means the neurosurgeon takes them to the operating room and tries to resect as much tumor as they possibly can without causing significant functional deficits. Often in the posterior fossa, the extent of resection is limited by the degree of involvement of the brainstem and things like that. So upfront maximal safe resection typically is the first step. There's a few exceptions to this though. So for germ cell tumors, these are highly radiosensitive histologies. And so we can often get away with a biopsy only. And if we have enough clinical suspicion and lab values are elevated and things like that, and that tells us that these patients definitely have a germ cell tumor, we sometimes don't need a tissue diagnosis. We can just, directly treat. So germ cell tumors are one of the exceptions to upfront maximal safe resection. The other exception, which I kind of mentioned previously, is if there's something like a diffuse intrinsic pontine glioma where even a biopsy is not considered safe because it's entirely involving the brainstem, then that is another situation where we sometimes have to treat without tissue diagnosis. Although I will say for DIPG, there is an attempt to try and get at least a little bit of tissue if possible, because this might be one of the only ways that we're going to be able to move the needle forward in this disease site where patients do very, very poorly. So we try for tissue whenever possible, just because it can help us guide management and also understand how to better treat these cancers. But that said, things like germ cell tumors, or if it's impossible to biopsy without causing damage to the brainstem, then oftentimes we have to forego the tissue diagnosis. But otherwise, for most other primary CNS tumors, I think upfront maximal safe resection is a safe answer for your first step in management. And then on this table is kind of listed out the different adjuvant radiation regimens that we think about, as well as chemotherapy and systemic therapy considerations. And as you can see, radiation does play a significant role in the management of most of these primary CNS tumors. One of the exceptions to this, which again I had mentioned earlier, is low-grade glioma, right? So for low-grade gliomas, such as juvenile pilocytic astrocytomas, even if there is a subtotal resection, so even if they have gross residual after their maximal safe resection, it's safe to observe these until progression, and we don't necessarily need to intervene with radiation just because they are low grade and they tend to not be very aggressive. The other tumor that can be observed after maximal safe resection is ependymomas if they are supratentorial and differentiated. But most of the time in pediatric patients, they are posterior fossa tumors, and so they're infratentorial, and we do end up treating with radiation. Now, craniospinal irradiation is something that you hear a lot about for the management of pediatric CNS tumors, and there are specific tumors that are routinely treated with craniospinal irradiation. The first tumor that comes to mind, which is routinely treated with craniospinal irradiation, is medulloblastoma. Another tumor is non-germinomatous germ cell tumors. So germinomas are typically treated with whole ventricular irradiation, and then they get a boost to the primary tumor. But non-germinomatous germ cell tumors get CSI, and then they get a boost to the primary tumor. Medulloblastomas also get CSI. The dose varies depending on the risk of the patient, and then they go on to get additional fractions for a boost to the primary tumor. ATRT, that atypical teratoid rhabdoid tumor, is another tumor that can get CSI as well. Ependymoma, we typically do CSI only if patients have positive metastases. So that's in contrast to medullo and ATRT, where they're getting CSI prophylactically. Ependymoma, we think about giving CSI only if they already have positive metastases. Now, the dose for radiation most of the time in pediatric CNS tumors is going to be 1.8 gray per fraction. And typical doses that we see for craniospinal irradiation are either 23.4 gray or 36 gray. And then the boost dose to where the primary tumor was located ends up being somewhere around 54 to 55.8 gray. Gliomas, if they are high grade, they typically get adjuvant radiation, but it's typically kind of an involved field radiation, similar to what we do in adult patients with gliomas. So the doses are 54 gray if they have a gross total resection, or 59.4 gray if they have a subtotal resection. And again, all of this is at 1.8 gray per fraction. I'm not going to go through this entire table in great detail because it would be too much to take in, but I just want to kind of leave this here for your reference, and then in future videos, as we go through each individual disease site, we'll kind of bring to light some of these different treatment paradigms. For now, just big takeaways, generally pediatric CNS tumors, whenever possible, are managed with upfront maximal safe resection. Germ cell tumors, we can get away with a biopsy only because these are highly radiosensitive histologies. The disease sites that we think about for CSI are things like medulloblastoma, non-germinomatous germ cell tumors, ATRT. These, we are thinking about CSI as kind of a prophylactic measure. And then, of course, if they do have positive spinal metastases, we can boost those as well. Epidemiology, we typically only offer CSI if the patients have positive metastases. And again, across all of these disease sites, we know that when we give CSI to patients that are less than 3 years old, they have very toxic effects. The neurotoxicity is really significant, and these patients often are extremely impaired moving forward. If we give CSI to slightly older patients, so older than age 3, they still have, life-altering neurocognitive effects, but it's not kind of it's not as disabling as if we were to do it to children that are less than 3 years old. So for children that are less than 3 years old, whenever possible, we try to delay the onset of CSI as much as we can with systemic therapy. But if we are giving CSI, we try to make sure that these patients are older than 3 years. We really try to avoid radiating with CSI for children that are younger. And then, again, as we said, the dose is 1.8 gray per fraction typically. Sites that we give whole ventricular irradiation, so just germinoma really is where we give whole ventricular irradiation and then boost the primary. And then sites that we give just kind of involved tumor irradiation, so epidemiology, as long as they don't have positive metastases, high-grade glioma, and then craniopharyngioma as well. So again, the general management I'm just leaving here for your reference. But then because CSI plays such an important role in the management of many of these pediatric CNS tumors, I would like to sort of end the talk by going through CSI and talking a little bit about the technique, how we set up our fields, how we match different fields for the brain versus the spinal fields, because this is something that does come up on tests and a technique that you should be familiar with. When we treat with CSI, we're trying to treat the entire brain and the entire thecal sac as defined by the MRI. So that usually takes us to the bottom of S1, S2. So brain plus the entire thecal sac. That is the entire craniospinal axis. So anywhere where there is CSF, we want to treat that entire area, right? Whole brain, entire thecal sac, all the way down, usually to the bottom of S1, S2, as defined on the MRI. So that is our target, and that's what we're trying to cover. Now, how are we actually going to cover that? So typically, there are multiple fields that we need. We need a whole brain field, which is usually done with 2 lateral beams, and then we need a spine field, which is usually done with PA fields, so posterior anterior field, a single PA field, and depending on how tall the patient is, we might need at least 2 or maybe more fields to cover the entire spine. Typically for pediatric patients, it's going to be a whole brain field with 2 laterals and then 2 PA fields. So one to cover the top half of the spine and another PA field to cover the bottom half of the spine. So these are our fields, okay? And each field is going to have a different isocenter. So typically we have 2 to 3 isocenters. So 1 isocenter for the whole brain field, and then 1 or more additional isocenters for depending on how many PA fields we need to cover their entire thecal sac. So when we simulate these patients, we really want to be conscientious of how our fields are going to be entering the patient and what we can do to kind of make that flow as smoothly as possible. So when we simulate our patients, we want to have them supine with their shoulders down and their neck extended and try to minimize any curvature of their spine. So why do we do all of that? Well, we keep their shoulders down so that when our lateral beams come in, our opposed laterals for their whole brain field, those fields aren't going through the patient's shoulders. So we try to keep the shoulders down as much as possible. We keep their neck extended because our PA field is going to have some divergence, and we want to avoid the divergence of that PA field from going through the patient's oral cavity. So that's why we try to keep the neck extended. And then we want to keep the spine as straight as possible because we want our PA field to be as narrow as possible and not have it go through a lot of unnecessary tissue, right? We don't want to irradiate unnecessary bowel. So we want to try and keep their hips kind of aligned with their shoulders and try to minimize curvature of the spine, kind of a sideways curvature. And we also want to try to minimize like lordosis and kyphosis and things like that. So to try and achieve all of that, we ask them to be supine, shoulders down, neck extended. We use a 5-point mask to secure their head and shoulders, and then a large vac lock for their body and check for straightness of the spine. And sometimes a knee sponge can help to reduce the lordosis of the patient or that lumbar curvature. And we try to keep these patients in this position, for the reasons that I mentioned. And keep in mind that oftentimes when we're treating pediatric patients, if they're very young, they might need general anesthesia to be able to lie still for the length of treatment. So that's simulation. Then when we're contouring, as we said, our target is the entire brain, and we want to ensure our field is covering kind of the cribriform plate, the crista galli. We want to cover that entire, that area as well as the base of skull. And then the entire thecal sac as identified by the MRI. And then I have a picture on the right-hand side of what the spine contour should look like. And we're not just including the spinal canal, but we're also extending along the nerve roots laterally to ensure that we're covering the nerve roots as well. So anywhere that there is CSF surrounding the craniospinal axis, we want to include all of that in our target. And then finally, as we said, when we're thinking about our fields, we're trying to have 2 lateral beams, so opposed laterals, to cover our whole brain field. And then we're having 1 or more PA fields to cover the entire spine. Now, this whole thing gets very complicated because of the flashlight effect, right? And that is if you shine a flashlight and you're standing 5 feet from a wall, you're going to have a certain radius of the light on the wall. If you shine a flashlight and you're standing 10 feet away from the wall, suddenly your radius that you see on the wall is going to increase, right? And that effect is known as divergence, where the beam's diameter, and a radiation beam is essentially a giant flashlight. The radiation beam's diameter increases with the distance from the source. So as a beam is going through the body, you have to imagine its divergence and the fact that because of scatter and things like that, it's also going to be, treating a wider radius as you continue to go through the body. So that is divergence. When we stack multiple fields on top of each other, we actually get hotspots that are created in the areas where the fields overlap, and we get cold spots located just behind that area of overlap. So that's what I've tried to show with the red and blue triangles here on this slide. We get hot spots where the fields overlap, cold spots just behind. So there are a couple of things that we can do during CSI to try and minimize that overlap and try to mitigate that hot spot. When we're thinking about the overlap of the divergence between the whole brain fields and the spinal fields, we have an advantage because they are on different axes, right? The whole brain fields are opposed laterals, and then the spinal field is actually coming in perpendicular to that. So when we're matching our brain and spine fields, we can actually rotate the patient in such a way that minimizes their divergence into one another. And we'll talk about how we can actually match those fields and how we rotate the patient and the collimator to try and kind of minimize the fields diverging into one another. We have the advantage of being able to do that for the whole brain and spine fields because they are on different axes. If we did that while we were treating the spine, though, we would end up probably missing some area, or it wouldn't work out to kind of rotate the patient in such a way to match the divergence. So in the spine, we're kind of faced with this flashlight effect where when we stack the flashlights, we get these hot and cold spots. So what we can actually do is minimize the area of those hot spots by what we call feathering the junction. That means every few treatments, we actually move the match line of these beams by about 5 to 10 millimeters so that we actually spread out the hot and the cold spots. It kind of helps to create a more homogeneous field, right? So instead of having the same exact position in which those flashlights are stacked for the entirety of treatment, we have them stacked at a certain measurement for the first 5 treatments. And then after 1 week, we shift them by about 5 millimeters so that their positions are now different. And then we shift them again by 5 millimeters after another 5 treatments so that their positions are different. And you can imagine that that then kind of helps to spread out where the hot spot is created, where the cold spot is created, and it helps to create a more homogeneous treatment. So this is a visual representation of what I mean by feathering the junction. Every few treatments, we shift the match line of the fields, and what that does is it shifts where the hot and cold spots are inside of the patient. And over time, rather than treating in the exact same positions for the entire treatment course and having that hot and cold spot be exactly where it was to start with, what we do is we shift where the hot and cold spot is every few treatments, and that ends up creating a more homogeneous dose distribution. So hopefully that gives a good broad understanding of what we're trying to achieve with CSI. Let's get into some more details and some of the specifics around how we design the fields, how we match the different fields. So starting with designing our isocenters and where these fields are going to be located. Typically, in an average height child, we're dealing with about 3 total fields, right? The first field for the whole brain, then the upper spine, and then the lower spine. So it helps to plan the upper spinal field first, that single PA field. And what we want to try to do is keep the upper border of the spine as low as possible. So ideally around C4, C5 or C5, C6, and depending on the child's height, it'll probably go down to about L1, L2. When we design this field, again, upper border as low as possible, and we want to avoid exit of that divergent beam through the oral cavity. Hence, we simulate the patient with the neck extended. Then we think about our whole brain fields, and we're thinking about giving 2 opposed laterals, right? So when we're designing our whole brain fields, we want to ensure that we're covering the entire brain. So make sure that field inferiorly covers the cribriform plate, the crista galli, as well as the base of skull. And we want to avoid entering through the patient's shoulders. It's okay for us to have about a 0.5 cm gap between the brain and spine fields. And then finally, on the opposite side of the patient, we want to plan that lower spine field and any additional PA fields if we need more than 2 to cover the spine. But typically, in an average sized child, probably 2 spinal fields will be sufficient. What we want to do is, as we talked about with that flashlight effect, wherever those 2 divergent fields match, wherever that match point is, just anterior to that, we're going to have a hot spot, right? And posterior to that is going to be a cold spot. So if you think about it logically, where would you rather have your hot spot? Right in the middle of the spinal cord or just anterior to the spinal cord? Hopefully you're thinking just anterior to the spinal cord, because we don't want to have excess hot spot right in the middle of the cord, right? We're okay with having it just anterior to the cord inside of the vertebral body. So when we match these spinal fields, just like what is shown in the diagram here, we want to have the match point of those divergences be just anterior to the spinal cord so that we get a cold spot in the cord and we get a hot spot in the vertebral body. So we've thought about our fields, we've thought about where we're going to place the isocenter. Now, the most complicated part of all of this is probably matching the brain and the spine fields. Because remember, the brain we're treating with opposed laterals, and that's going to have an inferior divergence into what we're treating with the spinal field. And then the spine we're treating with a PA field, and that's going to have kind of this upward divergence into the whole brain field. So we want to try to minimize the overlap between our brain opposed laterals and our spine PA field. So how do we do that? We can do 2 things. So when we're treating our whole brain field, rather than just slapping on two squares on either side of the patient, we can actually rotate the collimator so that the bottom edge of our brain field kind of parallels the upward divergence that's created from the PA field. And a visual representation of that is shown on the left-hand side of this table. See how we can see the PA field for the spine and its upward divergence, and then the collimator is rotated at a specific angle, so the bottom edge of our square kind of parallels that upward divergence that's created by the spine field. So there is a formula for calculating the degree of this collimator rotation, and it's given in that box below, but generally the angle is about 12 degrees. That takes care of the issue of the spinal field going into our whole brain field, right? That's sort of one plane in which we're seeing the divergence. But the other plane where we're seeing the divergence is from the whole brain field itself, there's going to be some divergence, right? Because even though we are angling the collimator to match the divergence of the spinal field, that whole brain field itself is going to have, it's like shining a flashlight into this page. So there's going to be some divergence into the spinal field. So the other thing that we can do is when we are treating for our spinal field, we can actually kick the couch towards the head of the gantry so that the top edge of our spinal field matches the downward divergence of our opposed laterals. So what I'm talking about there is represented on the right-hand side of these images, where we're actually rotating the couch so that the top edge of our spinal field is parallel to the downward divergence that we get from our whole brain field. And there is another formula to calculate the couch angle, the degree of the couch kick that we need. And that is also given in the formula underneath the diagram, but that angle ends up being about 8 degrees. So this is very difficult to wrap your mind around, and you probably need to draw it out yourself or stare at this slide for a very long time, or just hear the last 3 minutes of what I've said again and again and again. But once you wrap your mind around what is happening, and it takes me a long time to grasp these sort of three-dimensional concepts in my mind sometimes, but once you wrap your mind around what is happening, there are two things that need to happen when we match our brain and spine fields. Number one, we need to rotate the collimator for our brain field so that it matches the upward divergence from our PA spine field. And then number two, when we're treating the spine field, we actually need to kick the couch towards the head of the gantry so that the top edge of our spine field matches the downward divergence of our brain field. And there are formulas for that. So the formula is basically the angle equals the arctan of half of something divided by either the SSD or the SAD. So it's different depending on what you're calculating. So when you're calculating the collimator rotation for the brain field, it's half the spine field length divided by SSD. And then when you are calculating the couch kick for the spine field, it's arctan of half the brain field length divided by the SAD. Now, these formulas are very complicated, and I don't have a good explanation for why they are the way they are. This is just something that I memorized for the physics board exam, and I recommend you memorize it as well. But hopefully we at least conceptually understand what is happening and why, and then we can kind of just commit these formulas to memory and get those questions right on the board exam. The final little thing I'll mention here is, there's a big deal around the fact that the couch kick is toward the head of the gantry for pediatric patients when we're doing CSI. The reason, it can get confusing is because in breast planning, there's also a couch kick sometimes when we're using kind of a dual isocenter planning technique. And a couch kick needs to happen to deal with the divergence of the tangent fields and the divergence of our supraclavicular fields. And that's a whole conversation for a different lecture. But the bottom line is in breast planning, we deal with a similar issue when we're trying to match two fields when we're doing regional nodal irradiation. And there needs to be a couch kick that happens. The difference is in breast cancer patients, that couch kick is done away from the head of the gantry. So the patient's feet are moved away from the head of the gantry. Whereas in CSI, the couch kick is toward the head of the gantry. And the mnemonic to kind of remember that difference is think of hugging a child close to you and pushing an adult away from you. So when children are sweet, they're very cute, you pull them close to you in a hug, so the couch kick is toward the head of the gantry. Adults, not so nice, we push them away, so the couch kick is away from the head of the gantry. And that's the simple mnemonic. But just remember, for CSI, when we do that couch kick, it's toward the head of the gantry. Okay, so we've hopefully understood now the mathematical wizardry that goes behind matching those brain and spine fields. And then there's one last piece of the puzzle, which is matching our multiple spine fields. And we've already kind of talked about this, but now let's put the math behind what we've talked about. So as we said, we try to match the spine fields anterior to the spinal cord. It doesn't have to be anterior to the vertebral body, just right anterior to the spinal cord, so that we avoid the hot spot in the cord, and whatever hot spot we get goes in the bone, which is important, but less important than the cord itself. Whenever we match these fields, right, the divergence is matching within the patient, right, at a depth within the patient, whatever depth is just anterior to the spinal cord. What the therapists are going to see on the patient's skin, and when they're making sure that they're treating the appropriate field, they are going to see a separation between the two fields, and that's kind of shown in this diagram here. So from the therapist's perspective, they have the beam and they have a certain field size, and we understand that whatever field size is drawn on the patient's back, inside of the patient, that field is going to grow because of divergence. So the fields are matching at a particular depth, but what we see on the patient's surface is a separation between what we're treating on their spine. So what the therapist can do is they can actually place a marker on the skin and check the skin gap. And another problem that you might have to solve for physics board exam is calculating what that skin separation should be. And they will tell you that you're, trying to match fields at a particular depth. They'll tell you what the SSD is, and they'll also tell you what the length of your field size is on the patient's surface. And they'll ask you, well, what should the patient's separation be between the two fields? And one thing that you can do is just use a principle of similar triangles to identify what the separation is. And, one triangle is the SSD ratio to the length of the field itself. The other triangle is the depth of the field and then the separation that we see between the fields on the patient's surface. So you can use similar triangles, or you can memorize the formula that I have in that blue box. But either way, that's another formula / mathematical concept you should be familiar with for board exams. And that is basically calculating the patient's separation. And, one thing, when I was talking about how we simulate the patient, I have been taught that it's easier to simulate the patient supine, but I should also add that, it's possible to simulate the patient prone, and it's probably easier to kind of see these skin markings and exactly where the fields are on the patient if we simulate them prone. But that is probably an institutional preference and a physician preference in terms of how we simulate them. We can do CSI supine or prone, but it's probably easier to see these marks on the patient's back if we're simulating them prone. So we calculate that skin gap between the two different fields using the principle of similar triangles. And then going back to that concept of feathering the junction, as we talked about and explained earlier, we're going to have a hot spot in the vertebral body and then a cold spot in the spine that's just posterior to that match point of the two fields. So we typically try to move the match line every 5 treatments or so, so typically once a week, and we move it by about 0.5 centimeter to 1 centimeter max to kind of spread out where that cold spot happens, also where that hot spot happens, and get a more homogeneous distribution. So typically every 5 fractions, we're moving the fields on the order of about 5 millimeters. And essentially when we do that, what we're doing is just shifting where that match point is. So we're spreading out the hot and cold spots. Now, when we're doing CSI, whenever possible, we do prefer protons. And this is a retrospective study, first author Kahali et al. From the JCO 2020. And this retrospective study compared intelligence test scores between 79 pediatric patients that were treated with CSI for the same, for medulloblastoma on the same protocols. And the only difference in their treatment was the modality, so protons versus photons. And what they've found is that the patients treated with photons actually had significant decline in their global IQ, working memory, as well as processing speed, whereas proton group exhibited stable scores in all of the domains except for processing speed. So we do have data that protons are superior to photons in terms of neurocognitive outcomes. It's also thought that protons, because of their Bragg peak, will result in less dose kind of anteriorly inside of the patient, so less dose to the bowel, thus decreasing risk of secondary malignancy and things like that. So protons really are preferred whenever possible, but understanding that not all patients will have access to a proton center, photons can be used as well. In the modern era, there's some data for using VMAT technique rather than this complicated matching field CSI technique. And with VMAT, you still have different fields that are created, but then they end up creating a dose gradient over a 5 to 10 centimeter period. So, the dose from the top field decreases over a distance of about 0 to 5 centimeters. And then there's the adjacent field has kind of an opposite gradient where the dose increases linearly from 0 to 5 centimeters. So that kind of creates opposing dose gradients between fields. So that there is still some, complex math that needs to happen even for VMAT, but that is another option for treating rather than the fields that I demonstrated. But big takeaways here should be CSI, how we think about these fields, what we need to do to match them appropriately, and then, we have data that protons are better for CSI. The last few thoughts that I'll leave you with are kind of the toxicity from CSI and how we counsel patients on what to expect. So there are acute and late toxicities from radiation. And in the short-term period, it's typically what you would expect. So dermatitis, fatigue, hair loss, headache, nausea, vomiting. Patients may have diarrhea, and they may also have cytopenias from CSI. It's a pretty toxic treatment. The late effects, however, are probably what parents are most concerned about when they hear about CSI. And a big, kind of late effect is neurocognitive dysfunction. And, most patients that are treated with CSI, and the risk kind of increases with younger age, but they will need some sort of, kind of help in the future for intellectual disabilities. And they do have decreased IQ from craniospinal irradiation. They almost always also get, hypopituitarism and endocrinopathy, so they can have growth hormone deficiencies, hypothyroidism, gonadal dysfunction. They can have decreased growth in truncal height because of the dose to their vertebral bodies. And, one thing that we think about when we're treating kids that are still growing is actually prescribing a homogeneous dose to vertebral bodies. We try to cover them with a minimum dose, usually around 18 gray, across the entire vertebral body, just to ensure that they get a uniform dose. So one thing that we can do is, if we're not sure if the growth plates have fused or not, we can get x-rays of the hands and knees to evaluate. And then if kids are still not skeletally mature, we definitely need to make sure that their vertebral bodies are covered with a minimum of 18 gray, so that whatever kind of stunted growth happens from the radiation is happening uniformly. And if we didn't do that, then they might have kind of a heterogeneous growth pattern in their vertebral bodies, which would be not ideal. So we try to prescribe a minimum dose to the vertebral bodies, usually around 18 gray, just to ensure uniform growth for children that are not skeletally mature. Other late side effects we think about: weakness and ataxia, risk of fractures, risk of stroke, cataracts, hearing loss, necrosis, secondary malignancy for sure. And we talked about how meningioma can often happen from exposure to craniospinal irradiation in the past. And, depression and anxiety can happen as well kind of as downstream effects of everything that children go through from the CSI. So again, these are not at all insignificant. These are very kind of life-altering, very difficult for parents to hear, kind of the side effect profile from CSI. So it's very important to be familiar with these and kind of keep in mind, what to expect when we're counseling patients and families. I don't consider myself an expert in any of the topics that I cover here on Radonc Talks. I am learning, just like a lot of other folks, constantly learning and trying to improve. But I certainly am nowhere near being anywhere remotely close to expertise in the pediatric world. What I'm trying to present in these talks is really kind of textbook knowledge that will help for board exams and things like that. But again, I did not train at a proton center. I don't have a lot of experience treating children, and it's not something that I plan to specialize in. So again, all of these videos, take knowledge with a grain of salt, trust but verify, and things like that. And keep in mind that, for children, for folks that are actually treating pediatric patients, they are the ones that will have much more knowledge on these topics than me. I am just trying to provide kind of a broad overview to hopefully help learn very basics and help for exam purposes. So I hope that this talk was helpful to you. Again, we went through things very broadly, and in future discussions, I would like to kind of more deeply go into the commonly tested diseases such as medulloblastoma, ependymoma, and go from there for pediatric CNS topics. But hopefully this overview gave a general idea of the different types of pediatric CNS tumors that are out there, their differential prognosis, a general outline of how we manage these, and then ending with a review on CSI techniques and fields and how we match fields and things like that. So I hope this was helpful. Thank you so much for your time and attention.